penile urethra would give you a rough idea about the length of the bulbar urethra. So the bulbar urethra has a bulbar cone here. This part is the membranous urethra. It is constricted by the sphincter muscle. Oftentimes, just beneath the bulbar cone, you have a constriction-like thing. That is because of the compression nodae muscle. That is basically the bulbocamerosus muscle which is constricting this. It's not a stricture. And you have the sump, a wide sump. If you don't have this sump, if you don't notice this sump, likely there is a stricture. And the other point is the transobturator line. In instances where you have bulbar stricture and you don't know where is the bulbar cone, you can draw a line connecting the two obturator foramens, the lower part of two obturator foramen, the transobturator line. It gives you a rough idea about the position of the bulbar cone. A caveat to the reading of RCU is that the urethra proximal to a stricture can often appear distended because of hydrodistension by the urethra, by urine. So this fact has to be kept in mind. Talking about etiologies, bulbar urethra, it's mainly idiopathic followed by iatrogenic. So idiopathic strictures are basically encountered in young people. You have a short stricture in the proximal bulb, and there is also a significant proportion of individuals who have traumatic bulbar strictures. By traumatic, we mean straddle injuries, blunt blow to the perineum. Whereas if you look at penile urethral strictures, majority are inflammatory and iatrogenic. In the inflammatory, by and large, at this time, I think lichen sclerosus is the most common cause of inflammatory penile urethral strictures. So the current trends in urethroplasty, in anterior urethroplasty, is to not transect the urethra and to do minimal urethral mobilization as far as you can. The basic aim being to preserve the blood supply of the corpus spongiosum of the urethra, and hence thereby preserving the sexual function. So let's talk about bulbar urethral stricture. Bulbar urethral strictures are more commonly encountered, as we all know, than the penile urethral strictures or fossa navicular strictures. And there are two main options: anastomotic urethroplasty. Again, we have transection versus non-transection anastomotic urethroplasty. And of course, the most commonly done is the augmentation urethroplasty. So, but I need to say something about DVIUs or UDs. Even the American guidelines, they still state that DVIUs or urethral dilatations can be done for strictures up to less than 2 centimeters. I say it should be done for strictures less than 1 centimeters, strictures which are very soft, it doesn't look very dense, and the success rate is approximately 1/3 only, though the literature says it's 50%. And these patients, they often come with a repeat stricture. The American guidelines say that you should not repeat a DVIU if the patient has a restricture. The SIU guideline says that if the stricture has recurred after 3 months, then you can do a repeat DVIU once. An important point is that repeated DVIUs can exacerbate spongiofibrosis. A 1 centimeter stricture can turn into a 3 centimeter stricture. So one attempt you can do a DVIU, not more than that probably. Excision and anastomosis and end-to-end anastomosis is one of the most urethroplasty techniques which is associated with the highest success rate, usually indicated at present mainly for traumatic strictures as a result of straddle injuries. Why traumatic strictures? Because traumatic strictures as a result of straddle injuries are associated with complete obliteration. There is 100% spongiofibrosis, and these strictures are very short, so they can be easily excised and anastomosed. And the success rate reaches up to 95%, so it's a very high success rate. But there is a doubt that longer strictures cannot be excised. So this doubt was raised by Webster and Guralnik in 2001. Who cautioned that excising more than 2 centimeters of strictures can lead to penile shortening and ventral curvature of the penis. So the logic was that we all know if we resect 1 centimeter of bulbar stricture, we have to spatulate 1 centimeter on either side, and that leads to a 2 centimeter urethral defect. A similar sort of result was obtained by Richard Santucci in 2006, where in a small series there was a 18% incidence of erectile dysfunction and CORDY. Whereas in a very large series by Barbagli et al., in the subsequent year, there was no chordy or erectile dysfunction, even when they excised strictures up to 5 centimeter. The only sexual side effect was ejaculatory dysfunction or decreased glans sensitivity, cold glans. In another paper from the United States by Alan Murray, they showed that even 5 centimeter long strictures can be excised, provided the stricture is located proximally in the proximal bulbar urethra. They couldn't do a good anastomotic urethroplasty if the bulbar stricture was located distally. So in this series, there was not even a single case of chordy or penile shortening or erectile dysfunction, even when they excised strictures up to 5 centimeter in long, 5 centimeter in length. So these are some of the nuances. I think it is a straight for surgery. We all know about all of this. We shouldn't mobilize the bulbar urethra beyond the penoscrotal junction. And in case we think that we have some anastomotic tension, we can always do a pleural separation. Mind you that while doing a pleural separation, do not use electrocautery, use sharp dissection scissors. So augmentation urethroplasty is the mainstay of treatment of bulbar urethral strictures. And oral mucosal graft is what is used most commonly, though in the past people used to use penile skin as well. And literature also describes using graft from the urinary bladder, rectal graft, post-auricular skin grafts, but by and large the most commonly used is the oral mucosal graft. So we have 3 different techniques, I must say: ventral only, dorsal only, dorsal inlay, and a double face urethroplasty. Lateral only is not done these days. We do a dorsolateral only as described by Dr. Kulkarni in India. So ventral only technique was described by Murray and McIntosh. It is a straightforward surgery. We do a direct sagittal ventral urethroplasty, and an important prerequisite is that a wide sponge more than approximately 1.5 centimeter is required so that the graft bed is adequate. So ventral only surgery is ideal for middle and proximal bulbar strictures. Remember in the anatomy section I mentioned that the end of the bulbosus muscle is the point up to where you can do a ventral only urethroplasty. And the ideal situation is to do ventral only urethroplasty in post-URP proximal bulbar strictures. The so-called sphincter strictures, which we were taught as residents in the past, are actually proximal bulbar strictures. Now remember, the anatomy of the external urethral sphincter is omega shaped. It is horseshoe shaped. So if you do a dorsal only urethroplasty, you are likely to injure the external sphincter. So if you do a ventral only, you are very much likely to protect the external sphincter. So these are some of the pictures which I took from Barbagli's paper. The important nuances here is that while doing we should always keep a guide wire so that we don't miss the urethral lumen while we are doing a ventral urethrotomy. Always put a guide wire. Always use methylene blue to stain the diseased mucosa. Otherwise, you might get lost where to suture the way to take the bites when you are stitching the graft. And you can use this nasal speculum, or you can use the DBK forceps, or you can even use a gorget, as described by Mundi, to expose the strictured part. Incise only the mucosa and the fibrosed sponge. We should not incise deep. If we incise deep, it bleeds and it will be very difficult to take these bites. The initial bites are taken in the 6 o'clock, 5 o'clock, and 7 o'clock locations. The important point is that you should bend the needle into J shape. Use J-shaped needles. Push it with one needle holder. The needle tip comes out here, and use second needle holder to grab the tip of the needle. Rotate it, push it inside, and then bring it back. So that way you can take bites. Otherwise, it is quite difficult to take bites out here. So advantages of ventral only: you have direct access to the urethra, mobilization is not required, and you have remarkably easy access to the proximal bulb. But the important drawback is that it bleeds, and taking these initial 3 bites is quite difficult. And the other drawback is that there is less structural support to the graft, leading to increased incidence of diverticulum, saculations, post void dribbling, and all these things. So it enjoys a reasonably good success rate of around 85%. The surgery which I prefer is dorsal onlay surgery, which was actually described by Barberly in 1996. So it is derived from the technique of Monsieur. Monsieur was a French surgeon who initially did a dorsal urethrotomy, opened the stricture dorsally, and basically he anastomosed the opened urethra to the underlying tunica albuginea of the corpus spongiosum. So what Barberly did was, Barberly modified the Monsieur technique. He added buccal graft onto the corpus spongiosum, to the tunica albuginea of the corpus cavernosum, and established the widely accepted Barberly technique. Here you have to circumferentially mobilize the bulbar urethra, and we have to graft the oral mucosal graft to the tunica albuginea of the corpus cavernosa. So the graft taken and the graft which has been patched onto the tunica albuginea of the corpus cavernosa here. The advantage is less bleeding. It is versatile. Versatile meaning you can do it for a longer stricture as well. In fact, this is the surgery which we do for pan-urethral strictures. We can use a very wide graft, and there are no problems with saculations. Whereas while doing the drawback is that you tend to damage the circumflex arteries, and if the stricture is located too proximally, it can sometimes be difficult to place the graft. So it enjoys a success rate similar to ventral onlay, around 85% success rate. So we have variations of dorsal onlay. So we have, as I described previously, we have muscle and nerve sparing urethroplasty, wherein we basically retract. We don't divide the bulbospongious muscle. We basically retract it down like this when we're doing a ventral onlay. And Kulkarni in India described the one-sided dissection technique. We basically invaginate the penis into the perineal wound, and the bulbospongious muscle is retracted down, and the urethra is mobilized only on one side. So basically, it preserves the vascular supply. That is, it doesn't damage the circumflex arteries on the other side. So this is the one-sided Kulkarni urethroplasty. So lateral onlay urethroplasty was sort of brought forward by Barberly, but he did it only in 6 patients, and no more further papers are there regarding lateral onlay. So dorsal onlay is a useful technique, especially for penile urethral strictures. So I'll be discussing more in the section of penile urethral strictures. So how do we treat obliterative bulbar urethral strictures which are non-traumatic? Traumatic bulbar strictures are obliterative. Treatment is anastomotic urethroplasty. For obliterative non-traumatic bulbar strictures, we have 2 options. One is to do an augmented anastomotic urethroplasty. The other is to do a double phase BMG urethroplasty. Here, the advantage of one is we excise the disease. The advantage of other is that we tend to preserve the sexual function. So basically, in augmented anastomotic urethroplasty, we excise the most narrow or fibrotic segment, and then we anastomose the urethral plate and spatulate the urethra on the other side and augment it with graft. So this is all about augmented anastomotic urethroplasty. The advantage is that the diseased urethra is removed. The main advantage is, so my personal preference is for augmented anastomotic urethroplasty rather than parliamentary technique. So because the diseased urethra is removed, there is less chance of recurrence. An ideal indication for this is previous failed anastomotic urethroplasty. So the urethra can be anastomosed ventrally using where we call it a floor strip, using the graft dorsally, or we can anastomose the urethral strip dorsally, which is called Russell's strip, and use a ventral only of the graft, as seen in these 2 pictures. So here's the graft, this is the ventral only of the graft. So because we are removing the disease segment, the success rate of augmented anastomotic urethroplasty almost reaches the success rate of anastomotic urethroplasty. It's in excess of 90%. So what about double phase PMC urethroplasty? So double phase PMC urethroplasty was first described by Palminteri in 2008 on two premises. These premises are that anastomotic urethroplasty can cause sexual dysfunction, whereas if you use a dorsal only or a ventral only, a one-sided graft, it can be inadequate for tight strictures. So he did a dorsal inlay plus a ventral only in 2008, whereas a similar kind of surgery was described by Zellman and Stiesel, who did a dorsal only and a ventral inlay. So in this picture, we can see that the dorsal inlay is being done out here first, and then a ventral only of graft is being done. So here we have done a dorsal only and a ventral inlay of the graft. So this enjoys a reasonably good success rate, and in the series by Palminteri, there were no sexual side effects actually, whereas in a series from Hyderabad, India, Hemant, my friend, he did his, in a series, he had a 16.2% incidence of ejaculatory dysfunction. So though double phase is said to have no sexual side effects, the series by Incante et al. Has shown some degree of ejaculatory and erectile dysfunction. So coming with the non-transecting, the team by Anthony Mundy described non-transecting anastomotic urethroplasties for strictures up to 2 centimeters, and their indication were non-traumatic strictures. Their hypothesis was in non-traumatic strictures, the extent of spongiofibrosis is around 10%. It is not 100%. So what they do is they just excise. They open the urethra dorsally, excise the strictured mucosa and the spons, and then anastomose the mucosa here, and then finally close the urethral defect in a henicomiculous fashion. So their series, at a follow-up of 1 year, enjoyed a very good success rate. So in the same theme, Welk and Kodama described the so-called augmented non-transection anastomotic urethroplasty, the ENTA surgery, where for longer strictures which had an area of obliteration, they excise the stricture, they excise the stricture mucosa and the spons, did a graft, they anastomose this part, the mucosa, and did a graft only dorsally. So they also had a very good success rate.